Our next topic is COPD. Remember that according to NICE, a diagnosis of COPD in patient over 30 year of age who are smokers or ex-smokers. So smoking is an important criteria to make a diagnosis of COPD. First is that the person should be smoker or an ex-smoker because smoking is the most important risk factor for COPD. So a smoker or ex-smoker who present to you with exertional breathlessness, chronic cough, or regular sputum production. Any of them, breathlessness, chronic cough, or regular sputum production, you will suspect a diagnosis of COPD. How will you confirm your diagnosis? You will confirm your diagnosis on spirometry and reversibility testing. There will be obstructive pattern on spirometry. Obstructive pattern is FEV1 over FVC ratio is less than 70% or 0.7, and a negative reversibility testing. So the diagnosis of COPD will be confirmed on spirometry. Other investigations that are done include chest X-ray. Chest X-ray will show hyperinflation, bulla formation, and flat hemi diaphragm. These are the signs of chronic obstructive pulmonary diseases on chest X-ray. Other purpose of doing chest X-ray in patient with COPD, we all know that smoking is an important risk factor for lung cancer. So to exclude lung cancer and to see the signs of COPD, we can do chest X-ray as well, along with spirometry. Full blood count can also be done. Full blood count, if full blood count show eosinophilia, then we'll say that the person is having some asthmatic features because eosinophils are increased in allergic conditions. Whenever there is hypersensitivity reaction in the body, eosinophils, type 1 hypersensitivity reaction has an increased eosinophil counts. So doing a full blood count can reveal secondary polycythemia due to hypoxia or low oxygen, and the person with COPD will have secondary polycythemia, and also it can show eosinophilia. So if eosinophilia is present in a patient with COPD, then we'll say that the person is having asthmatic feature as well. Now, staging of COPD, how the severity of COPD is categorized using the values of FEV1. If FEV1 is, just remember the values of FEV1 for stage 1, 2, 3, 4, and 5. If FEV1 is 80% or more than 80% of the predicted, then we'll say that it's stage 1 COPD, mild COPD. If the value is between 50 to 79%, then we'll say it's stage 2. Value between 30 to 49%, stage 3. And the value of less than 30%, stage 4, or very severe COPD. So remember the mild and severe one. For mild, FEV1 will be more than 80%, and for severe or stage 4 COPD, FEV1 will be less than 30%. And in between them will be stage 2 or stage 3 COPD. These stages usually won't be asked in the Plab 1 exam. You just need to remember the very severe form of COPD, that is FEV1 of less than 30%. Because if someone has a severe COPD, then he need to be assessed for long-term oxygen therapy or LTOT. That's why it's important to remember that what is the criteria for stage 4 COPD or very severe COPD. So the diagnosis is confirmed on spirometry, obstructive pattern with negative bronchodilatory reversibility testing. X-ray will show hyperinflation, bulla, and flat hemi diaphragm. CBC will show polycythemia, secondary polycythemia due to hypoxia. Now, the management of COPD is very simple. General management include annual influenza vaccination and one of pneumococcal vaccination and smoking cessation advice. These are the things that are included in the general management of COPD. That is annual influenza vaccination annually and one of pneumococcal vaccination and smoking cessation advice. Now, which are the drugs that can be used in the management of COPD? Remember that glucotrain receptor antagonists they are not used in the management of uh, COPD because there is no inflammation or hypersensitivity in COPD. So LTRA is not included in its management. Steroids are also not included in the management of COPD. They will only be included in the management of COPD if the person with COPD have asthmatic features or steroid responsive features. So the only drugs that are used in the management of COPD, they are bronchodilators. Bronchodilators such as SABA, SAMA, and LABA. They can be used in the management of COPD. Steroids can also be used. When we can use steroids in the management of COPD, the indication to use steroids in the management of COPD include is that the NICE recommend that if the patient has asthmatic or steroid responsive features, how we can assess if the patient has asthmatic or steroid responsive features. Remember these 4 points. If there's any history of asthma or atopy, then steroids can be used. And on CBC, there is high eosinophil count, then steroids can also be used. There is substantial variation in FEV1 over time, at least 400 ml. Then we can say that asthmatic features are present and steroids can be used. And there is substantial diurnal variation in peak expiratory flow of at least 20%. So if a person has a history of asthma or atopy, a higher blood eosinophil count, substantial variation at FEV1, and substantial variation in peak expiratory flow. Remember these 4 points. If they are present, if any of them is present, then steroids will be included in the management of COPD. Otherwise, steroids will not be included in the management of COPD. So the first drug will start in the first step, we'll add a SABA or short acting beta agonist. And if no asthmatic features are
Can
present,
you explain about
yes,
this diurnal peak expiratory flow? So
diurnal peak expiratory flow variation means daily or day to day or peak flow variation in 24 hours of at
right.
least 20%.
Sorry, at least
Yes, of at least 20%.
20%. Okay.
Because in asthma, there is a reversible bronchoconstriction. So a person will, with asthmatic feature will have a substantial variation in peak expiratory flow. While on the other hand, in COPD, there's permanent damage to the airways, so the obstruction is permanent. So
Right.
in COPD, the variation will be less than 20%. If a person make his peak flow diary, then the variation will be less than 20% if he is purely COPDian. But if asthmatic features are present, then it means steroids can be used because they will help in bronchodilation. So
Right.
this criteria can be used. That is substantial variation in FEV1 and substantial variation in expiratory flow. So if
Okay.
any of these four features are present, then steroids can also be included in the management of COPD. So in
Thank
the first step, the first drug is SABA. Now, if there is no asthmatic features or no steroid responsiveness, then we can add LABA plus LAMA. We can add the long-acting bronchodilators such as LABA or LAMA. And if asthmatic features are present, then after SABA, we'll give LABA and ICS. So very simple, I'll repeat it. SABA, if no asthmatic features, LABA plus LAMA. If asthmatic features are present, in the second step, you will add two drugs. If no asthmatic features, then the two drugs will be LABA and LAMA. And if asthmatic features are present, then the two drugs will be, because asthmatic features are present, so one drug will be LABA and the other will be ICS. And if the patient still remains breathless, then you will add the third drug as well. Triple therapy, LABA, LAMA plus ICS. So this was management of stable COPD. The general management included smoking cessation and annual influenza vaccination and one pneumococcal vaccination, and then bronchodilator therapy, SABA, a short-acting muscarinic or bronchodilator, muscarinic antagonist or beta receptor agonist such as SABA. And the first step, any of them can be used. Now, depending upon the asthmatic features, our second step varies. If there are no asthmatic features, then two drugs that are added will be LABA and LAMA. And if asthmatic features are present, then two drugs that will be added in the second step is LABA and inhaled corticosteroids. And if there are
What is
still
the example
symptoms,
for llama?
LAMA example is tiotropium.
Sorry.
Ipratropium is an example of SAMA, short-acting muscarinic antagonist, and tiotropium, TIO, tiotropium is an example
Trophy.
of, yes,
Okay.
tropium drugs are muscarinic antagonists.
Right.
Tiotropium, ipratropium.
Okay.
So for patient with COPD who are taking LABA plus ICS or LAMA plus LABA, you can offer him or her triple therapy if his day-to-day symptoms continue to adversely impact their quality of life, they have severe exacerbation, or they have two moderate exacerbation within a year. So someone on two drugs, you will offer him the third drug if he or she is still having symptoms or severe exacerbation or moderate exacerbation within a year, two moderate exacerbation within a year, or their day-to-day symptoms impact their quality of life. You will offer the third drug. So if someone cannot tolerate the inhaled therapy, or if someone still has symptoms even after giving all the three drugs, that is LAMA, LABA, and ICS, then you can try oral theophylline. So after prescribing short and long-term bronchodilator, if the patient is still having symptoms, then oral theophylline can be tried. So NICE has only recommended theophylline after trials of short and long-acting bronchodilators. So this is the criteria to prescribe oral theophylline, only after trying all the bronchodilators, short-acting and long-acting. And still no improvement, then you can prescribe oral theophylline. Or to the people who cannot use inhaled therapy, to them you can also prescribe oral theophylline. Oral theophylline dose should be reduced if macrolides such as azithromycin or clarithromycin or fluoroquinolones such as moxifloxacin and levofloxacin are prescribed. Then oral theophylline dose should be reduced because they interfere. There is a drug interaction between these two drugs. So that's why you need to reduce the dose of oral theophylline. So three drugs that we use in the management of COPD, they are LABA, LAMA, and ICS. And if there is no response with these three drugs, then oral theophylline can be prescribed. Mucolytics can also be given to the patient who has complaint of chronic productive cough. Now, there is a complication of COPD that is known as cor pulmonale. What is cor pulmonale? Due to hypoxia, what happens in the lungs is that there's a vasoconstriction. Whenever there is hypoxia or low oxygen in the lung, low ventilation, what happens? The lungs vasoconstriction occurs. So vasoconstriction will result in pulmonary hypertension, and pulmonary hypertension will lead to, so which side of the heart will be failed in case of pulmonary hypertension? Right sided heart, because right ventricle will need to work extra to pump blood against the pulmonary hypertension. So with time, right sided heart failure will occur. So cor pulmonale is right sided heart failure due to pulmonary reasons. Due to pathology in the lungs, the right sided heart failure that result is known as cor pulmonale. And what are the signs and symptoms of right sided heart failure? So a patient who is a known case of COPD and he present to you with peripheral edema, raised jugular venous pressure, and loud P2 or systolic parasternal heave. Your diagnosis will be cor pulmonale. The management of cor pulmonale is either a loop diuretic to treat edema and long-term oxygen therapy. ACE inhibitors, calcium channel blockers, alpha blockers, they are not recommended for the treatment of right-sided heart failure due to lung pathologies such as cor pulmonale. The only treatment of cor pulmonale is long-term oxygen therapy. So remember this complication of COPD, that is cor pulmonale or right-sided heart failure in patient with COPD. And symptomatic treatment is to manage edema. We prescribe loop diuretic, and to manage other symptoms, only long-term oxygen therapy is recommended. What is the criteria for long-term oxygen therapy that we are going to discuss in a short time? Before discussing criteria for long-term oxygen therapy, we need to discuss management of acute exacerbation of COPD. So stable COPD was managed with three drugs, LABA, LAMA, and ICS. Or if there is no response with these three drugs, then oral theophylline. Now, acute exacerbation is managed with nebulized, either to increase the frequency of bronchodilators or to give nebulized bronchodilators in the form of salbutamol or ipratropium. So the management of acute exacerbation of asthma and COPD is almost same. All the same three things are used in the management of acute exacerbation of COPD, and the same three things are used in the management of exacerbation of asthma, that is oxygen, steroids, and nebulized bronchodilators. So management of acute COPD exacerbation include oxygen. Remember that 100% oxygen is not given in the COPD, because if we give 100% oxygen to a patient with COPD, his respiratory drive will diminish. Respiratory drive is simulated by hypoxia. So if we give 100% oxygen to the patient with COPD, his of hypoxia will diminish and his respiratory drive, there will be hypoventilation. And when there is hypoventilation, partial pressure of carbon dioxide will increase because it will not be excreted through lungs. So the patient can develop type 2 respiratory failure or CO2 narcosis. That's why in the management of acute exacerbation of COPD, we give 24 to 28% oxygen by a venturi face mask. Venturi face mask is a normal mask that does not create a positive pressure, unlike the mask of BiPAP, that is positive pressure ventilation. So the mask of positive pressure ventilation creates a positive pressure at the mouth, and the venturi mask does not create it. So oxygen should be given to the patient with COPD very carefully because it can diminish their respiratory drive and can lead to increased partial pressure of carbon dioxide and CO2 narcosis or type 2 respiratory failure. So management of acute exacerbation of COPD is oxygen 24 to 28%, and the target saturation should be up to 88 to 92%, and not 98% that is in the case of acute asthma exacerbation. So 28% oxygen, target saturation of between 88 to 92%, nebulized bronchodilators, and prednisolone 30 milligram for 5 days. The management is almost same as acute exacerbation of asthma. And if there are signs of pneumonia, such as fever high grade, or if the sputum is plurulent, then we will also give antibiotics. Otherwise, antibiotics will not be given in the management of acute exacerbation of COPD. Antibiotic will only be given if the signs of infection or is present or if the sputum is plurulent. So oxygen, nebulized bronchodilators, steroids for 5 days, and antibiotics if signs of pneumonia are present. Now, if the patient does not improve with this management, that is oxygen, bronchodilators, and steroids, then we will go for non-invasive ventilation. What is the criteria to use non-invasive ventilation in a patient with acute COPD exacerbation? We will use non-invasive ventilation as the treatment of choice for persistent hypercapnic ventilatory failure during exacerbation despite optimal medical therapy. So despite optimal medical therapy, if the patient is still going into hypercapnic respiratory failure, then this is the first criteria to use non-invasive ventilation. So if after oxygen, steroids and antibiotics and nebulized bronchodilators, the patient does not improve and he go into hypercapnic respiratory failure, then we have option of non-invasive ventilation. While in case of asthma, if the patient does not improve with triple medical treatment, then we have the option of IV magnesium sulfate. And in children, we have the option of IV theophylline, IV magnesium sulfate, and IV salbutamol. While in COPD, if there is no improvement with optical medical treatment, then optimal medical treatment, then we use non-invasive ventilation or NIV. So antibiotics, if signs of pneumonia are present, steroids for 5 days, inhaled or nebulized bronchodilators, controlled oxygen 25%, 24% with venturi face masks with a target saturation of 88 and 92. Aminophylline can also be given if the patient is wheezy and not improved with nebulizer alone. and if still no improvement, then non-invasive ventilation. Now, long-term oxygen therapy. Long-term oxygen therapy are given to patients with COPD, and once they are on long-term oxygen therapy or LTOT, the supplementary oxygen is given for at least 15 hours a day. Which patient require long-term oxygen therapy? Which patient you will assess for long-term oxygen therapy if the patient has core pulmonale. Signs of core pulmonale, that is peripheral edema, raised jugular venous pressure. So either the signs of core pulmonale or severe COPD, that is FEV1 of less than 30%, or if there is cyanosis, polycythemia, or oxygen saturation of less than 92. If any of these features are present, then you will assess the patient for long-term oxygen therapy. Three of them are related to oxygen, that is severe COPD, very severe COPD, FEV1 of less than 30% of predicted, oxygen saturation less than 92, and due to less oxygen, either polycythemia or cyanosis. So four of them are related to oxygen, and the fifth and sixth are related to core pulmonale. So if any of these six features are present, then we will assess the patient for LTOT. How we are going to assess the patient for LTOT? It's very simple. We are just going to do a test that is known as arterial blood gases on two occasions at least 3 weeks apart. So patient with any of these features, we will assess him for LTOT. And how we are going to assess him for LTOT? It's very simple. We will do arterial blood gas analysis on two occasions at least 3 weeks apart. And which patient will receive LTOT? If the patient PO2 on these arterial blood gases that is done on two occasions at least 3 weeks apart, will offer a patient LTOT if his PO2 is less than 7.3 kilopascal and PO2 is between 7.3 to 8 kilopascal with secondary polycythemia, nocturnal hypoxemia, peripheral edema, and pulmonary hypertension. So we'll offer LTOT to patient whose oxygen is less than, partial pressure of oxygen is less than 7.3 kilopascal, or partial pressure of oxygen between 7.3 to 8, along with one of secondary polycythemia, nocturnal hypoxemia, peripheral edema, and pulmonary hypertension. Such patient will be offered LTOT. And once LTOT is started, patient will receive oxygen therapy for at least 15 hours a day. But if the patient is on long-term oxygen therapy and he present to you with worsening of the symptoms, then a short course of steroids can be prescribed for 5 days. Either a 5-day course of steroids or add a normal saline nebulization to the management of the patient. So LTOT will be given to the patient with partial pressure of oxygen of less than 7.3 or partial pressure between 7.3 to 8 and polycythemia or raised jugular venous pressure, peripheral edema, any of these features, polycythemia. And if the person is on LTOT, long-term oxygen therapy, and still he gets dyspneic, then a short course of steroids for 5 days or nebulized normal saline will be added to the patient's management. Already on long-term oxygen therapy, but still breathless, prednisolone or nebulized normal saline to loosen the circulation. So this was all about COPD and its management. I hope it's clear to everybody. If there is any question, then you people can ask.